Good evening, everybody. My name is Ibrahim. I'm a neurosurgeon, and we are transmitting live from here from Amman, from the Farah Medical Campus. Again, the backdrop here is Wadi Rum in Petra, one of the most elegant places to visit in Jordan.
It's a beautiful picture.
Also the
And very nice sceneries there. Invite everybody from outside Jordan to visit. And there are some fancy places to stay in Wadi Rum. Our topic for today is Cavernoma affecting optic chiasm from the clinical, radiological, operative, and pathological sides. To speak about Cavernoma, I have to take the general overlook of vascular lesions. That is according to the International Society for the Vascular Anomalies classification. So vascular lesions are either neoplastic or non-neoplastic, tumors or vascular malformation. Vascular tumors like meningoblastoma, meningioblastoma, meningiomas, etc. And these are the non-tumors, non-neoplastic vascular malformation. If we take the vascular malformation and classify them according to the function, they are either with shunt, arteriovenous shunt, or without arteriovenous shunt. The with arteriovenous shunt are AVMs, fistulas, and venous aneurysm. The ones without shunt are cavernomas, which is our topic for tonight, capillary telangiectasia, developmental venous anomalies, and sinus pericranii. Just to remind you about sinus pericranii, connection between the outside and the inside veins of the brain, capillary telangiectasia like this one, and the DVA, or developmental venous anomalies, which will take some few slides for tonight because they are important. So back to Cavernoma. Old names for this Cavernoma, this is acceptable term nowadays. Everybody accepts this terminology. No one at all is using these terminologies, but we have to mention them just in case you come across them. Cryptic AVM, and cryptic means that we don't see them on angiogram. Occult AVMs, we don't see them on angiograms. Cavernous malformation, occult malformation, cavernous angiomas, cavernous hemangiomas, all are obsolete names. So what is Cavernoma? Why did we choose to call it cavern? Cavern or liqueurs, spaces, like caverns, are angiographically immature, thin-walled structures. They do not contain brain parenchyma, and they are low-flow regions. So there are multiple spaces, multiple sizes of spaces filled with blood. But they have this ability, endothelial proliferation, and increase in new angiogenesis. That's why the vessels are fragile and they can bleed. So cavernomas are tangle of vessels which resemble blackberry. If you like blackberry like myself, you would imagine what is the cavernoma is. People think that cavernomas don't have arterial and venous supply. They do, but they are so tiny you don't see them on angiogram. These are some of the cavernomas that I removed. Out of the cavernous, out of the malformations of the brain, they constitute 2 to 17% of all the vascular malformation of the CNS. They could be single, solitary, or multiple. Solitary is more common, 2/3, 1/3. Funny enough, the solitary ones are middle-aged, and the multiple are young age. No sex predilection, and this is the common age, 2nd to the 5th. But beware, they can affect pediatric age group. So this is collection of pediatric cavernomas. And where are they? In the brainstem. They love to go to the brainstem in the pediatric age group for no known reason. And this is very important, that cavernomas are associated with DVIs. So this is cavernoma, and this is the developmental venous anomaly. Dr. Faridiano, we are here.
Yes.
Is this observation
Very,
common?
very common.
Very common. To find cavernoma and
Yes.
Epidermis. Any interventional radiologist? No. Okay.
And the reason for that is
No one
no
knows.
one knows. It's just a reason.
To be accurate, there are theories for that. And the one who did most of the work on this is Dr. Assam Awad. He's a Lebanese residing in the United States. He's one of the big figures of the vascular pathology. He's done a lot of work trying to find the correlation. He put some theories. I don't want to indulge into this very deep topic, but we don't know basically. We are just postulating.
Probably the importance comes during surgery for that association is crucial.
Of course.
And that's the most important part of that association.
I was just wondering if there's a genetic predisposition for it. There's usually genetic
There
ties.
may be, yes, Marwan, some speculation about that. But the one thing I learned as a trainee, and this was discussed many times, that if you find a developmental venous anomaly, don't come near it because the end result is fatal. So you don't want to play with these TVAs. So this is cavernoma, and this is the developmental venous anomaly. That's why this cavernoma takes this position.
So,
Sorry, we have a bad connection with the States. So the association between cavernomas and developmental venous anomaly is to be remembered, especially by young neurosurgeons. So, there is aspect that you face it in children and in others, the developmental venous anomalies, and this is one patient of mine. Bahrani boy, 11-year-old, came with a signal palsy on the right side. He's looking to the right side, his left eye is moving, his right eye is not. So it's signal palsy, and this cavernoma on the right side of his pons. And look at the developmental venous anomaly. So, and this is for you, Marwan. Initially, all cavernomas were thought to be congenital. There is evidence now they can be acquired. And this is of very importance regarding the insurance companies. Insurance companies don't treat congenital anomalies. They keep asking me for reports that this region is congenital. I say, no, this is not congenital. It could be congenital, it could be acquired. So beware of this, because usually insurance companies, they don't want to pay anything. So there are genetical familial connection there. They can come after radiation, they can come after virus infection, they can be more in females due to hormones. So they can be inherited, and the side of inheritance is autosomal dominant, and different genes have been identified. Here is the work of Sam Awad, my dear friend in the States, who has spent his life working on this. He's one of the big shots in the United States.
there is no chromosome 79.
Maybe I put it wrong. So inherited, and it is common in Hispanics and Mexicans. It could be acquired, like this. And usually when they are acquired, they are multiple. So this is a kind of familial cavernoma, multiple small ones. So they are related to radiation. You give radiation for malignant tumor, for leukemias, for whatever, hematological or brain tumors, and then you will find you may develop cavernoma. Or you develop it, as I said, de novo. This is in moya disease. Another one, de novo, in existing developmental venous anomaly, the association which we mentioned. So they can be congenital, they can be hereditary, and they can be acquired. Multiple cavernomas are less than single ones. Single ones are more, as you said. But this is important. When you have multiple, 50 to 85 have the familial type. So you have to do some counseling, genetic counseling. This is kind of multiple cavernomas. This is a paper from Finland. Long-term outcome of patients with multiple cerebral cavernomas. What should you do with this? The paper say you go for the culprit, you go for the big ones if it is causing a problem. Finland is very famous neurosurgical vascular center. They have in Finland the highest rate of subarachnoid hemorrhage in the world. So if you want to train in vascular neurosurgery, you go to Finland. Size could be small, could be large, could be giant. I'll show you two giants in my cases, in my series. This girl, 21-year-old, was a story that she was neglected in treatment in governmental hospital, so she went to the radio stations and she announced her problem. She was healed by Queen Rania. She was referred to us and we operated upon her. We removed this giant cavernoma. So the idea that cavernomas come small is wrong. They can come in giant size. Last week, just last week, we operated on this giant young man, 27, coming from Hebron, from Palestine, with this giant cavernoma. So the question is, can these cavernomas grow? Yes, they can. They grow because there is interlesional hemorrhage inside it, or the vessels get thrombosed and swollen, or by the process of organization, recanalization. So this is a follow-up of this cavernoma that developed into this. So again, can they grow? Yes, they can. Different examples. Look at this one going into this size, and this one going to this size, and so on. How do they present? They present with something. So usually they are symptomatic at some point in one's life. But autopsy studies have shown around many people who died of other causes and they were found to have cavernoma. So you may live your life with a cavernoma without it causing symptoms, or it can give you symptoms at some point in your life. The common symptoms are seizures, and that's very important in children, or hemorrhage. Of course, you can have headaches, or it can be incidental finding. This paper is important, the importance of seizures in cavernomas, especially in children. So sometimes you do just surgery to alleviate the seizures. The other risk is bleeding. How often they can bleed? The annual bleeding risk or rate is 2.7%. Of course, the rate varies. Some people will get 0.4 to 5, but this is the accepted range for the annual bleeding. It means that after 2 years it's double, after 3 years it's double, and so on. But if you bleed and you bleed again, then the chances are 5%. And it is higher, the bleeding, in the infratentorial, which is the difficult ones, the brainstem ones. And it is higher in deeper cavernomas. So deeper cavernomas, brainstem cavernomas, they bleed more than the others. If you bleed, 80% you would have a transit deficit. 20% you have permanent deficit. If you bleed again, 100% you have permanent deficit. That's why we have to treat these cases. We don't want people to live with permanent deficits or die after that. Now this is an important issue, and I think it is misunderstood by many doctors and by many practitioners. The hemorrhage in a cavernoma. The people assume that whenever you see hemosiderin around the cavernoma, that this has bled. It's wrong. You may see this without a bleed. So to define a bleed in a cavernoma, this is the acceptable equation. Either there is acute or subacute blood located outside the hemosiderin ring. So you would see mixed signals, hemosiderin ring, and then there is a bleeding outside. So this is definite proof that you have blood. Or there is increase in size in the lesion, 20%, and it is associated with mass effect or edema, like this case. So there is a bleeding outside, and there is edema. cerebral venous malformation, natural history from Canada, Toronto. And this is the edema again. So whenever you see this, you see there's a bleed. But not everything you see with hemosiderin means that they have blood. Where do they occur? Locations. Anywhere. They can affect the orbits. I've done many cases. In fact, the commonest orbital tumor I've done is cavernoma, and in many other people's series, it is the commonest tumor. So, cavernoma. It can be done by the ophthalmologist, it can be done by us as neurosurgeons. So it can be anywhere through the brain, but supratentorial is far more than infratentorial, which is lucky because infratentorial are difficult ones. Supratentorial, again, they could be superficial or deep. The commonest affection, frontal, more than temporal, more than parietal, more than occipital. So this is one of my cases. This lady with this huge cavernoma and after surgery. Frontal, deep frontal, inside the ventricle, and so on. Another patient of mine, 2 years. 2 years, male patient with this needle temporal cavernoma. So different locations. Occipital is rare.
You can identify them radiologically?
Yes, I'm coming to that. This is a very rare paper actually, that they can present like a meningioma, like a dural-based lesion. So the surgeon who operated on this thought that this is meningioma, it is dural-based, it's penetrating the bone, eating the bone. Now, as he reflected the one flap, the tumor is inside, but it turned out to be a cavernoma. Or it could be intraventricular, as I said, and all ventricles, lateral, third, fourth. Like in this case, and the third. And the brainstem, as I said, infratentorial. And this is a paper from Solomon in New York. Brainstem. And midbrain, of course. This is midbrain. Different parts of the membrane, tegmentum or the posterior part. Tectal plate. Look at this, affecting the tectal plate. Or it could be in the junction between midbrain and the pons, affecting pons and midbrain. This is total pontine inside the pons. This is one patient with mine with pontine hemorrhage from Iraq, 32-year-old. He came with this pontine hemorrhage. He was devastated neurologically with multiple cranial nerves. I operated upon him. This is the post-operative and sent him home. More pontine cavernomas can be in the medulla, which is a critical situation. So medullary cavernomas. Again from Finland, spinal AVMs. This is a case of mine, a lady from Emirates with this cavernoma on the side of the spinal. Images are on. CT can show you this as hyperdense or calcification with mass effect. And this is actually one case I was dealing with as a resident in London. Again, you can see this on CT, but here you can see the developmental venous anomaly. MRI is important, which I mentioned. This is a lesion, multiple spaces, different sizes of spaces or caverns filled with blood, and this blood will change in the consistency, so you'll find oxyhemoglobin, deoxyhemoglobin, methemoglobin, hemosiderin. The presence of hemosiderin does not mean that it bled. And that's the wrong assumption of so many people. So be careful to say that this has bled. As I said, we have the two conditions, bleeding outside the hemosiderin ring or increase in size by 20%.
Does it exclude hemorrhage within the tumor?
Of course, it is, no, of course. It has, the hemorrhage is two types, inside the or outside. So Just assume that there is hemosiderin and that's it, but if it bled inside, it will increase in size.
Hemosiderin is the byproduct of hemoglobin.
Yes, exactly. So it is well demarcated, interregional hemorrhage surrounded by hemosiderin rim, etc. These are the sequences, the flare, the S1W, the contrast, and this is MRI, and this is very important, gradient echo. It is the best to show the cavernoma and the hemosiderin contrast.
Nowadays we are using the SWI, which is more
Yes.
accurate than...
I'm coming to that, yes, of course. And this man came, Joseph Zabromesky from Barrows Institute in the United States, a very famous center for cerebrovascular disease, and he said we will classify this AVM into classification. So it is known as the Zabromesky classification. His associate, maybe his boss, is Robert Spitzler, who did the classification for the AVMs and the aneurysms. So he said we'll classify them into type 1, type 2, type 3, and type 4. This is subacute hemorrhage. This is different ages called the popcorn. This is chronic hemorrhage. This is punctate. Let's see examples. Type 1, hyperintense on T1, hyperintense on T2, acute. So this is a Zabromesky type 1, T1, T2, T1, T2. Zabromesky type 2, which is called different ages, popcorn. Examples of type 2. Type 3 is the chronic hemorrhage, black. And type 4 is punctate, small punctate hemorrhages. So, Zabromesky classification from Barrows centers. If you do angiography, there is no identifiable arteries or veins because they are there, but they are so small you don't detect them on angiogram, and hence the name cryptic AVMs in the past. Rarely vascular blush, you may see abnormal draining vein, a pooling of contrast in venous state or stage. Then came this, susceptibility weighted, which is unique and it topped everything, it topped even the gradient echo. A lot of people don't know about these images. It is called susceptibility weighted image, where you see these blood vessels in a very beautiful way, and if you put one of these in an exam, in neurosurgical exam, nobody would answer it. So look at this, T2 here, the echo gradient here, and susceptibility here. Look at how you see also the developmental venous anomaly. Again, look at here, how you see the details of the lesion and the draining veins. And then, if you want to have more information, you will do tractography to see what is the relation of the lesion to the main tracts. So this is one of them, this is a cavernoma, and you want to see each tract where it is in terms of the anatomy. So what is the management of these cases? Some people would consider conservative management. I do sometimes for certain conditions, and I'm happy to discuss, but very few. Microsurgery is the best, radiosurgery is big no. It's a big no. I say it loudly and clearly. Big no. You should not.
What do you mean by conservative?
Conservative that you...
Just leave it alone and see what
Yeah.
happens.
They'll come to you, especially in the incidental cases, and then patient has no symptoms, no problem, then you would say, I will do it. Because surgery entails risk. So you would say, surgery entails 3 to 5% risk, incidence of hemorrhage is so and so, it did not bleed before, so you may consider to do that, especially if it is deep-seated. Radiosurgery, why I'm saying no? I'm against calling it gamma knife. It is radiotherapy, stereotactic radiotherapy, let's face it. There's no surgery in it. So people who say, I am a radiosurgeon, they are giving them the name of a surgeon, and they are not. They are radiotherapists, they are not surgeons. But even that, how would you know that you have treated a lesion which you cannot see on angiogram? This is one point. Bullock in States, Carson in Karolinska Institute, two famous places for stereotactic radiotherapy. This is a very famous paper by Carlson and his colleagues in Karolinska. I trained at Karolinska, so I know them personally. They treated 22 cases with gamma knife. 9 bled after radiosurgery. 8, they had complications. So really, you would say 17 out of 22 had problems. So results of radiosurgery are inconclusive. And remember, you have to wait for 3 years to see what's going on. When you say surgery for cavernomas, immediately comes to your mind Robert Spitzler. Robert also from Burroughs Neurosurgical Institute in the States. And as I said, his student and his colleague is Ibrahim. And here he wrote this paper about brainstem. In fact, he authored a book on this, which I have. So this is Robert Spitzler. We are here together in many places around the world. In this particular instance, I was lecturing, he was there, and he killed me with his questions. Here he is at my home, at my place in Oman. This is my wife offering him our coffee. Here we are in Oman. Here we are discussing a project in Jordan. And we are members in the World Academy of Neurosurgery. So I'm proud to say that I'm associated with Robert Spitzler. Of course, he came and visited Jordan and met with His Majesty. I was there with the king. Another name that must be mentioned is Juha Hernisemini from Finland with his colleagues, especially Mika. Mika and Juha, if you go for any conference about vascular, you will find both of them are there, transmitting live surgeries from Helsinki. So they proposed this grading system on brain and spinal cavernomas, 2011, which is acceptable. Grade 1, Grade 2, Grade 3, Grade 1 supratentorial deficits, Grade 2 supratentorial with deficits, Grade 3 is infratentorial. Very famous. And this is J.R. Nissini. This is his picture with his boss in Canada. This is him. In fact, you can say easily, and in fact one of his papers mentioned something like 4,000 middle cerebral aneurysms, which is a huge number. He's the most proliferative man in terms of surgery. He would do middle cerebral aneurysm within 1 hour. Usually his assistant would open, he would just go and clip it. And he would do with aneurysm things that he would be frightened to do. And again here, he was there when I was lecturing. He's now retired. He's serving in China for no money. He's just going there to help them teach the young generation. My interest in vascular neurosurgery is very old. And this is my first paper. And I put this to entice our residents and younger neurosurgeons. 1984, I was resident. So I made this paper, I wrote it, Traumatic Capital Cavernous Fistula. And in which journal? Journal of Neurosurgery. Dr. Hamoui, you were there with me in London, we were studying and etc. To be able to publish a paper in the most famous journal in the world, in Journal of Neurosurgery, as a resident, is something to be proud of. And also I published this one, 1986. Also I was still a resident with my boss, Sean O'Leary, but I've done the whole job. And we reported the cryptic AVMs, or the cavernomas, and the brainstem. At that time we used to have just CTs, so these are the CTs. Direct approach on brainstem cavernomas, published in Neurosurgery. So now the topic for tonight. It's a cavernoma of the optic chiasm. So let me just look with you at these, are they common or not? The optical chiasmatic cavernous in general. In general, cavernomas affecting cranial nerves are very rare, but they can be a cause of visual disturbance. And there are some predisposing factors in predisposing symptoms, alcohol, etc. By the way, vascular lesions are affected by hormones of the female, by contraceptive pills, by so many hormones that they use. So hemorrhage could be, this is related to Imad, could be extralesional or intralesional, but the extralesional are most common. So extralesional is more common than the intravenous. And if they are extra, they will have presentation like subarachnoid hemorrhage, or even intracerebral hemorrhage. I'm talking about chiasmatic cavernomas. They can bleed and present with subarachnoid hemorrhage. Surgery here is to stabilize or improve visual deficits according to what you do. Papers from USA 2010, cavernoma formation of the optic pathways and the hypothalamus, analysis of 65 cases in literature, and these are the cases. So we're talking about 65 cases in the whole of the literature. The names of the authors and the year, and so on. You don't have to read it. Another paper from UK 2008, again of the Chiasm cavernoma. Again, they put the authors. 2014, this paper affecting the optic nerve. And this 2013 also affecting the optic. And paper from China. And paper from Germany. And from South Korea. So, our patient, 44-year-old female Jordanian lady, she had visual disturbance of 2 months duration. She went to various ophthalmologists, and it kills me that ophthalmologist does not diagnose this. A young patient with visual deterioration, you have to have image. A young patient with decreased hearing, you have to have image. But we keep going around the bush, beating around the bush without going to the actual diagnosis. So, cesarean section in the past, nothing in her vital signs, general examination, Glasgow scale 15 over 15. I will come to that examination of the eyes, but basically she had bitemporal hemianopia. Here she is, no motor deficits. Her eye movements are okay, so no third, no fourth, no sixth, but the optic is affected. No cerebellar signs, and no weakness in her limbs. Chest X-ray ECG normal, and blood tests were within normal. Imaging. Look at this. You can see there is a lesion there. Actually, you can see the gyrus rectus and the olfactory tract, and then the optic apparatus, and there is something sitting there. This is a live view. Optic nerve, something sitting in the lab. في حضن الأوبتيك cancer. Here it is. Yeah. Restriction. And this is the lesion. So you have so many differential diagnoses for this, which I will touch on. Look at this. This is the stroke. This is the lesion. If you follow the optic nerve in the orbit, which is the round one surrounded by the subarachnoid hemorrhage, go deeper, 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 then you find the lesion. It is subarachnoid fluid. What did I say?
Hemorrhage.
Subarachnoid fluid. Of course. I'm used to hemorrhage. So, again, you can see the lesion, you can see the stroke, and it is sitting in front of it. Here is this fiesta kind of view, oblique view. You come and you see it there. There, 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 and there. Skull X-ray, somewhat enlarged cella. And I remember in the past when we did not have the MRI, our bosses used to ask us what is the diameter of this and the diameter of this, diameter in the third space, so that you can speak about the volume of the cell. CT, angiogram, to exclude aneurysms, nothing is there. MRV, again, nothing is there. So what's the differential diagnosis? Optic glioma. And this is one patient of mine with optic glioma. Sacral aneurysm. Lucky enough, I did not have aneurysm lurking in the dark for me there. But sacral aneurysm can present like this, exactly like this, like the cavernoma. Microadenoma of the pituitary gland, especially if going to one side, can mislead. Radke's cleft cyst. Look at this. Again, this patient was presented under this roof about a few months ago. You can see the stalk and you can see the Radke. I put you the pre-operative and the post-operative. Craniopharyngioma, again, patient of mine, 16-year-old. Meningioma. Optic glioma, as we mentioned. Histiocytosis, and again we presented histiocytosis under this roof, and we showed that they love the optic and the stalk and the epidermis. Pilocytic astrocytoma. We don't think of these pathologies as if they don't exist. Anything in the cellular area, we're used to common sentences like a cliche. Cellular, supracellular region, a figure of 8, the snowman appearance, this is pituitary. We have to stop this, we have to be deeper than this. We have to put differential diagnosis. Neurosarcoidosis. Imagine if you give this, niamanite. You will kill the patient. Germinoma, and we presented the germinoma last time here. I showed you this. And this Iraqi girl, if you remember. Metastasis. Metastasis and the optic chiasm, yes, just like the cavernoma and the optic chiasm, just the same. They can happen. Why not? Lymphoma, and lymphoma is always mentioned when this man.
And this is
When he
not
walked in.
prearranged. I really have
He
to
walked in.
emphasize
He walked
this
in.
is not prearranged, and it never fails every single time.
It's coincidence. It's not coincidence. So the differential diagnosis is very wide, and we have really to think about it, and it has to be mentioned in the reports. I say the duty of the radiologist is not to describe what he sees. أنا أتكلم على الزلمة اللي بيكون أعلى الشراع في سفينة القراصنة. هناك سفينة ذات طابقين. No, we have to tell how many guns are there, how many machines, how many people are there, so that you help us arranging the thing. But most of the radiologists, they say our duty is to describe, not to give a differential diagnosis. I disagree.
So, what is an oncologist doing in a cavernoma session? This is exactly why. And I can't condemn enough, as Professor Sbeih had done already, the practice of radiating what looks like a cavernoma without knowing what this is. You can swear for all practical purposes that these look exactly the same as what we've seen already. And had this been irradiated, this patient would have been denied not necessarily a curative treatment, but treatment that would have been radically different and that would have really affected his quality of life. Lymphoma in this setting, radiotherapy first line is the wrong thing unless it's purely palliative and the patient is dying. These patients would need high-dose methotrexate or things like that. Metastasis can really look like adenoma, and these patients may have not been examined properly, and you would miss lesions in the breast or the testes, etc. I can't emphasize enough that metastasis from the testis or from the ovaries in the brain does not preclude treatment with curative intent, and I cannot really emphasize this enough, which is exactly what leads us to germinal. These patients with brain lesions that look like adenoma in this case are treated with curative intent. And missing sarcoid with radiotherapy and letting patient die of sarcoidosis is a crime. Knowing that this is astrocytoma is important because the protocol is different. Histiocytosis, the treatment is radically different, and if you just give radiotherapy to that specific site, the patient will succumb to a disease that they should been able to live with for a long time. Optic glioma that can really masquerade as such, and meningiomas, craniopharyngiomas, Radke clefts. I cannot emphasize this enough. These are actual cases. And a lot of these would have gotten a label that they look like vascular lesions. These are cavernomas sent to radiotherapy, osteostatic radiotherapy, or gamma knife, or X knife, or what have you, and they die with the evidence buried with them because we never knew what these patients had.
So always think of differential diagnosis and make plans to prepare yourself for the ultimate confrontation. Consultation, Dr. Ibrahim.
Good evening. So I had the pleasure of evaluating this interesting lady who is also my relative. So I was involved in every step of management of this lady. So basically for us it's a supracellular chiasmatic lesion, whatever the cause. All this differential diagnosis for us is the same. All of them present in the same manner. All of them cause bitemporal hemianopia. All of them compress the anterior visual pathways. All of them cause decreased visual acuity and color vision. So our role as ophthalmologists is to detect that there's a problem. This lady presented 1 month ago to my colleague and he gave her just simple glasses. I think that if he just did confrontation visual field, he might detect something. So our role is to document things and to see the prognosis. So I'll show you something and we will continue at the end of the lecture. So basically there was more compression on the left side than the right side. There was afferent defect in the left. Active, I think there was afferent defect, bitemporal hemianopia, thickening of the nerve fiber layer. Let's see. So that's what I am showing you. There's still greenish, whitish elevation here, thickening of the nerve fiber layer, and there's here some red color. So this goes with thinning of the nerve fiber layer. We tell Dr. Ibrahim that this will not get improved after surgery much, but this is our golden period of interference. So let's do something and save this eye. And I think that's what he did. This is the frank bitemporal hemianopia. Notice that in a lot of supracellular diseases, pituitary disease, whatever, the visual field is not only bitemporal hemifield, it bypasses to the other hemifield as well. It does not respect anatomy much, unless it is a pure dissection from trauma, for example. So let's continue after that.
So she did not improve from the first doctor, basically.
No, she was treated for 2 months with the glasses, eye drops, and you name it, and psychological, and you name it. She was announced threat for anesthesia. This is our consent form, which I keep insisting that we should mention. And this is just some of the anatomy that one has to remember. So pituitary, the stroke, the nerve, the chiasms here. This is the chiasmatic recess. This anatomy has to be mastered if you want to treat patients with these lesions. Stroke, the nerve, the chiasm. So the lesion has been sitting here, sitting in the lap of the optic chiasm. So optic nerve, and stroke going to the chiasm. These tiny little vessels, very tenacious.
Beautiful picture.
Yeah. But imagine people do brain surgery without microscope, and patients get blind because they don't see these vessels. And when they say neurosurgery is microscopic, they say this is microscopic for old age. Now we are young, we can see well. You cannot see these vessels. And we were trained like youngsters on microscope. So that's how people would be blind because of this thing. Again, nerve chiasm, the carotid relation, and the ophthalmic artery, Dr. Mahmoud al-Khatib, relationship with the optic chiasm. Look at this 3D of the optic chiasm. So let's see surgery. So here we are. I use the transbasal approach. So you go between the two hemispheres. I do cut the superior-sagittal sinus at its most anterior part. I come across the olfactory tracts, which I preserve. I preserve every olfactory tract I'm coming across. Yesterday we have done a case, the optic, the olfactory were not existing. So you can see the black lesion.
That's it, huh?
Olfactory, and this is olfactory, this is the optic nerve, cutting the arachnoid here, then I get more space and CSF drainage. But look at here, you can see the lesion. Nerve, and this is the lesion. Some fibers of the chiasm are seen through. So the white is the normal chiasm, and the black, as it seems through the white, is the cavernoma. Now you have to stop and think, what should you do? Now you tackle this. But I am prepared, just in case it was an aneurysm, that aneurysm clips are ready, mounted on the table. If I don't know the differential diagnosis, I would not be prepared.
And you were saying that it's well circumcised, right?
Yes, it is well circumcised, but it is in the chiasm. So you have to dissect it of the chiasm, and that's the risk. With these tiny little vessels that we mentioned.
You can't see the extent distally.
Yes, of course, you can see it like this. Yes, of
You
course.
can see it?
Yeah, you can see it, as I said. These are the fibers
Yeah.
of the chiasm. So you are seeing it through. So it has gone through here. It has gone through here.
Yeah.
That's why she has the bitemporal and the crossing to the other side defect. But again, you can just raise the white flag and say I surrender, or you just try to help this lady. So I decided to go through that, and I don't look at the clock at all. There are some surgeons around the world who are, I'm calling them Speedy Gonzaleses. For them, neurosurgery is tut and then go out, and this is rubbish, to say the least. Neurosurgery is very planned surgery that takes time and effort. You don't want to stay 10 hours or 12 hours unless you have to. But to do surgery in 2 hours to say that I'm Speedy Gonzales is nonsense. I received some comment about that from last time when I said that my record in your surgery stands at 22 hours. That was in the past. We were just in the beginning, so we used to take our time. But nowadays, if a surgery takes 10 or 12, it's because it deserves 10 or 12 hours. Yesterday, we have done surgery of 12 hours, yes?
Yes.
So you have to find the plane of the cleavage, and there is usually one. This is a benign tumor, so why not? I'm here cutting in the lesion. I'm not cutting in through the fibers. But this is a decision you have to make. You have to be brave, and your bravery comes from your experience, from your knowledge. Don't be brave on the expense of the patient. Be brave when you are really prepared from the knowledge point of view and the experience point of view. As I said, this is interhemispheric approach. I could use it through the terional, but I decided this one so that I would see. Definitely, if I went terional, I would not have the pleasure and leisure of seeing all these information. It is hair-raising experience. This is a young patient, 40. Their husband and children are waiting outside, and they are thinking of what I'm going to tell them. What did I do? Did I really help the patient or not? I always put myself with the family and think of one of my relatives is inside, and the anxiety I feel waiting for a word about my patient.
Was that a big bleeder?
No, it's just the blood inside coming out, and with the CSF you have this.
Makes sense.
Yeah. I'm just here trying to find a good plane of cleavage between the chiasm and this thing. I'm finding it, so I'm more courageous now. At this stage I thought, well, I've got that. Always I feel during surgery that I'm a tiger following a deer, and the deer is running around and I'm following him. At one stage I feel I killed the deer. I put my jaw on his neck, and I am in charge. At this point, I remember I said, I am in charge. So no Speedy Gonzalez is here.
It's roughly adherent to the optic apparatus, yes?
Yes, of course it is. But you have to find a good plane of the cleavage in the gliosis area. So this is a flattened chiasm, flattened, like a chair. So this is kind of the back of the chair, this is the seat itself.
I
It is
think wrong plane will cut the chiasm.
absolutely,
Yes.
absolutely it will cut it. So it's total removal. I'm checking here on the stroke and the others, this is the stroke, to make sure that I have removed it completely. And the stages and so on. Okay.
So,
So-
you don't do chiasmatic decompression surgery.
No, of course not. Yeah, Dr. Professor, please, histopathology.
Assalamu alaikum. I'm Dr. Sam Farah. This slide. See, this case was the cavernoma of the optic chiasm. You can see typically huge dilated vascular spaces with the gliosis. This is the gliosis, and these are the vascular spaces. They are abnormal vascular spaces, not the one that you used to see in good histology slides, and there are small capillaries also scattered, and they are arranged in haphazard pattern. This is the typical of glioma, of cavernoma. You can see this is the huge and compressing adjacent glial tissue, and you can see how they are really not having a good wall. This is very typical to see not having a good wall for cavernomas. Variable sizes of blood vessels and the gliosis around them. Next slide. This is the huge blood vessel with fibrin sometimes in it and dilated vascular spaces. Next. This is CT31. We use CT31, it's an endothelial cell marker. I mentioned before that we have 4 major endothelial markers, CD31, CD34, and factor 8. We use them to delineate the vascular spaces. You can see there are some endothelial cells in this area, this vascular space, some endothelial cells. Some of them will be detached because of the dilated wall, and some of them probably they do not have lining, it's fibrous capsule because of the dilatation. And some of them are compressed together as in this area. But this is, it tells you where the endothelial cells are located in this cavernoma. This is GFAP stains the brain tissue, and this is the negative image, which to show you where this is the gliosis, and these are the blood vessels, and to show you how the blood vessels, they are abnormal shape, abnormally located, and they are compressing the adjacent brain tissue. Next. This is S100. I did S100 because S100 usually stain nerves. But remember, this is not a nerve tissue. Optic nerve is a brain tissue. So this is should be negative, and it is negative in this case. So this is we do usually Ki67. Ki67 usually is negative or below 1% in all cavernomas, or most of cavernomas, and as is this case. So this was a case of benign tumor. We called it cavernoma. Thank you.
So she woke up on table, fully conscious. No one is allowed to leave the room unconscious or not with it. If there is a problem, I have to know it immediately and try to deal with it immediately. There's no place for putting the patient on a ventilator عشان يرتاح, عشان نريحه. This is the immediate post-operative MRI, the very following day. We don't delay it at all. And this is the patient. And within 4 days she was discharged. This is her discharge summary. I keep harassing you about this, just for the young generation, maybe they would actually insist on doing this. And this is when she came up to the clinic for follow-up. After 1 year, this is her MRI. You can see the chiasm was still beautiful. Okay. 2 years follow-up. Again, you can see.
Is there a reoccurrence rate?
Yes, of course, if you don't remove them, they will recur. That's why the first time is the best time, and there's no second time. Again, let's finish. So this is the rest of the MRI. 3 years follow-up. There's the lady. And this is before surgery, and this is after surgery. So I'll ask Dr. Ibrahim to come to compare the preoperative visual status.
So her main complaints were visual, and we see pre-op visual, and then we did many visual fields on here. For example, this is the report on pre-operative, then on 4th of March. This is an improvement. Look how it is better. The color vision is better, visual acuity is better, everything is much better. So, and we do progression analysis to see whether there is any recurrence of the disease.
Did you get any improvement in the other eye that had the red in the OCT?
Yes.
Did you get any improvement in that eye?
Yes, actually, the visual acuity was 0.7, and it was 1 after the surgery.
So there was some improvement.
Yes.
So there was improvement in vision, which is
The visual field didn't improve so much.
improved dramatic.
Yes, okay.
It was bypassing the vertical midline.
Oh,
Now it is dramatic improvement.
okay.
So, thank you very much. Any questions or comments?
So there was improvement even in the eye that you thought there might not be.
Yes. The idea of surgery is to stabilize, and if you gain something, this is a bonus.
But a lot of ophthalmologists said that there's most of times there's no improvement of visual field deficit after surgery, and it may increase after surgery.
Of course
Yes.
it is, in the hands of the mediocres. Question.
I wish Dr. Ala stayed because he may have contributed to the answer as well. So there is growing evidence for AVMs and some cavernomas response to some biological agents, especially Avastin. What's your feeling about that?
Sorry, I did not catch that.
There is growing evidence and literature that there is some role for some biological agents to treat vascular malformations, including cavernomas, like Avastin.
Yes.
So what's your input? And I wish Alaa comes back and see you'll be excited about this, I guess.
I know about it, but I don't have any input. But as I said, Hassan Awad is working on this. He's publishing lots of papers on that, but I don't think it is in the practical stage. It's just in the theoretical stage.
Interestingly, I think the way people found about it is people being treated with Avastin for other reasons and having incidental cavernomas that disappeared on follow-up MRIs. And they're seeing some of that even on the AVMs. So it's amazing where the science is going to take patients away from surgeons and interventionists and just keep them with medication.
But not in our time, maybe
Yes.
after that.
هو إذا كان فريش ليجن it can improve سواء سيرجيكي أو ميديكي. دكتور محمد جمعة مرة حول لنا حالة كانت فرانك بايتنج هيميانوبيا المريض frustrated after 1 month of Dostinix everything disappeared. Disappeared. So yes, they can improve once you catch them early.
You mentioned there are 4 stages for cavernoma. Any difference in the treatment?
No.
No prognosis.
No, not at all. the so-called Zabramiski classification, yes.
I'm not sure if this is related to this subject or not, but those kids that were born with facial cavernomas, they have responded very well to propranolol. Do you know that? But I guess it's different situation. Yeah, capillary mature. Yeah.
And they respond well to saline injection into the cavity. Any question?
Do you face any problem to diagnose stage 4 with secondary amyloidosis?
Of course. It's very difficult. Multiple metastasis, cysticercosis.
Was in SWI?
Yes.
We have two. Yeah.
Sure. It is difficult, yes. Any other question, please?
Is there any increased incidence of diabetes insipidus in such cases?
Of course.
Because they could compress the.
In fact, last time we mentioned about the histocytosis, that if you have a child with diabetes insipidus, histocytosis is the most likely diagnosis.
I know that you against radiotherapy in cases where there should be surgery. I know that.
Not me.
But
it's not me personally.
Some books
it's
say,
in science.
Yes, some books, although some books say that in inaccessible lesion, and you know that inaccessible, for me, inaccessible for you is accessible. For inaccessible lesion, okay, deep-seated, you may give radiotherapy.
No,
It's mentioned.
I'm not living in Africa, in the middle of nowhere, and if I have surgeons who can do the surgery,
especially in a brain stem or.
But if you are living in Africa, and you may, and then there's no surgery there, you may give radiation. So this is an excuse.
They give radiation here in Jordan.
I know. That's why I'm mentioning it.
I saw many cases. I saw many cases with the brain stem, actually with the brain stem cavernoma, and they said for radiotherapy, not stereotactic radiosurgery, for radiotherapy.
It is because this mediocre
Dr.
surgeon cannot
Bilal,
operate. It is so obvious. To have a biopsy and send the glioma for radiotherapy is because they are mediocre surgeons, and there are so many around. And I'm not fearful at all of saying this, saying it loudly, that we have to stop this crimes against humanity in Jordan. Please.
Is there family genetic testing in Jordan for this disease?
No. In general, it's weak, but in the world itself, it is, we know that they are genetic, we know they are familial. I don't know how good they are, but from previous experience,
No, there's some significant, but not here.
Yes.
Not in Jordan.
Because in my short time in Jordan, I encountered already 2 families who have multiple cavernomas. So clearly they exist in our country.
Definitely.
They just
Definitely. The Lebanese gentleman that the doctor was referring to has quite a few cases. There's some studies that are doing it, but in the U.S., not here, on a trial basis.
As we mentioned, Hassan Awad, and he's a close friend of mine. Last time we met in Beirut, he was, if you are a good surgeon, it is like you are a fortress. Everybody wants to destroy that fortress because they cannot conquer you, so they attack you. Yes. So they produce excuses for their being mediocre surgeons. And they would quote papers which does not exist, or quote experience which was not there. I had this experience when I was in Glasgow. No, nonsense. They're just saying lies to save their necks and to keep going, taking money of people for no good reason. Well, thank you very much. We'll see you next week.